smoother with this, but all right. So today I was feeling a little bit of a sort of shift in the way that things have been going. Um, and then there was a storm that shifts all of that. But so far with the COVID-19 and the epidemic and the way it's worked, a lot of it has been focused, sort of self-focused on how it's affecting me, individually, what I'm dealing with in those circumstances, all of that kind of thing. But as the data came out this week, I felt that I was starting to shift a little bit. Part of it is this has become quite routine. For me, at least, I was counting it up, and today is day 29 since classes shut down, and I determined that we were going to be doing this in this way. So it's been almost a month of quarantining, or at least social distancing, and it's getting routine. We're also starting to see that we're past the peak around here. That doesn't mean that we're safe by any means. The people calling for us to end this are being far too premature. As soon as we do, it will come right back. It's not like it's died out, or that it has a course the way that a thunderstorm does when it comes through. But we've got a handle on it, right? We seem to have managed it. The worst things that could have happened, in the worst projections in our area, have not come true. We haven't exceeded capacity in a dramatic way, although we've come very close. We've managed to keep it in line. We're starting to see the size of this thing. And so this week, some data has come out, which probably all of you have heard about, right, that highlights some of the injustice within our healthcare system. We've seen in particular that African Americans and Latinos are dying from COVID-19 at a higher rate than whites and Asians and other groups like that. And so it was significant in the gap was significant in Louisiana. The deaths were about 70% African American, where African Americans make up about 30% of the population. So it's a massive difference in the proportions. Exactly the percentages have changed a little bit depending on whose data you're looking at over the week at different points. Governor Edwards noted this difference, has even put together a task force to start thinking about it. If you look at data from other areas, you see a higher prevalence of Latinos. Louisiana doesn't have such a large percentage of Latinos, so it doesn't stand out in the same way. But African Americans and Latinos seem to be being affected more by COVID-19, dying more often due to COVID-19 than other groups. So this is a time for us to step back as humanists and think a little bit about justice and belief, and how those might work, right, and how those might interact in these situations. It's a lesson in both how science works, because it's being played out in front of us publicly, and at least one of the ways that racism works for us to look at, because that's also being played out publicly, or at least being highlighted publicly right now. A commitment to humanism can help us think about how to approach this and appreciate some of the dangers as we think about these problems. Okay, so what are the hypotheses? Why might these two different groups be affected differently than the rest of the population? And I was just paying attention to the news, coming up with the different ones that were out there. One possibility is something fundamentally biological, like genes or some sort of innate susceptibility, that's just higher within African Americans or Latinos than it is within the rest of the population. This was being floated by some doctors early on and has been discussed a couple of times. There's some other possibilities as well. Underlying health conditions have come up. So COVID-19 is exacerbated if you have diabetes, if you have hypertension, if you have obesity. Basically, if you have problems breathing or immune problems of some kinds, then you're more likely to die from it. If you get it, it's likely to be more severe in those cases. So there can be underlying health conditions. Maybe those are more prevalent in Latino and African American communities, and that would explain this problem. People point out some other social factors that were there that are significant as well. One of them is that COVID-19 spread through some of the wealthiest population first. The people who had contact with people from Italy and China and other places like that tended not to be the less wealthy communities. And so it got a a reputation, sort of perception, as being a disease of those people, right? Of those circumstances. So if you didn't live in those circumstances, you may have been a little slow to react, to think that it applies to you. I've heard floated the hypothesis that Latino and African American churches continue to meet and met more often. And that is something that spread the disease more. Another possibility are the occupations that are held in these communities. These are tend not to be occupations that could be done from home. So if you clean houses, you have to go out and clean houses. You can't stay home and clean houses remotely or something like that. That's not a possibility. So if they're engaged in manual labor or service work or something like that, maybe they got more exposed. Living conditions would be another possibility. It is harder to quarantine at home if your home is small, right? If you live in a small apartment with 4, 5, 6, 7 people, it's going to be tough to stay in just that little apartment. You're going to need to get out. If you've got more people in your household, um, if they're still working, if they're still going out, then there's more risk, right, that it can come back in. So larger houses and smaller households, right, might explain some of these differences, or smaller houses and larger households, however you want to look at it. So I've heard all of these hypotheses floated in one way or another in one other news program or by different people at different times. All right, so what should we make of this? How should we be thinking about this? How should we filter through these hypotheses? I think people's preferred approach. I mean, the thing that I notice, right, is that people tend to run to one of these very, very quickly. They'll tell you, this is the one, this is it, this is how it happens. That they know that this is what happens. I think when somebody does that, right, what they're doing is they're showing you something about their character, right? There's one of these that they need to believe. It's not a matter of the evidence. It's not a matter of thorough examination of each case. There's one of these that they need to believe. So let's think about how these all might work. And I think that can help us sort of untie a little bit about what's going on here. And let's go through them backwards from the order that I listed them in. So if we think about, say, living conditions, churches and occupations, like some of these social factors that might have been part of this, we can ask various questions about how that got created. Why would it be that African Americans and Latinos would live in smaller apartments in larger groups? If that is in fact the case. It seems likely to me, but I haven't seen the data to back that up. But if that is in fact the case, which may be, it's probably the result of discrimination, housing discrimination, making it harder to afford larger houses. Discrimination against immigrants in the case of Latinos are fairly likely to be part of the factors, right, that go into creating these larger households. If in fact the African American churches met more frequently even after the warnings, which again is not something I know happened, but even if it did, right, this could explain this could be looked at in terms of the importance of that church to that community, right? If people continued to get together, it's because they needed it in one way or another. Of course, the history of the African American church in supporting that community and holding people together and helping them deal with hard times can explain why this might have happened, if in fact it did. Occupations, again, we've got a similar story. Why would these occupations that put people at more risk also be occupied by people that are African American or Latino? Discrimination comes forward, right? We've got various systematic factors that might be behind every one of those, if any of those are the explanation. What about underlying health conditions, right? Diabetes, things like that might be driving this. That sounds like a simpler biological process that is in part, or can be in part, a product of various kinds of choices that people make. But even here, we can see an interaction between a history of racism, structures of racism, patterns of racism, and the choices that people might make within those contexts. So diabetes can be caused from a number of things. One of them that at least exacerbates it, doesn't make it worse, can be a bad diet and poor exercise habits. So maybe, again, maybe, right, these are more common within certain communities. Maybe Latinos have a tendency, I know Latinos have a tendency to eat more sugar and enjoy those kinds of things. That's just a cultural pattern that could be part of it. Maybe that's an exacerbating factor. maybe a lack of exercise, maybe a bad diet. But if we think about the structures that are behind those choices, we can look again at the way that racism might have shaped them. So we can look at the food choices that are easily available. So part of it is a question of access, right? So food deserts is something people have talked about, areas where there aren't easy access to fresh vegetables and so on. That's certainly part of the story. It's hard to get to it. Healthy food can also take more time, right? You need time to cook it. You need pots and pans to make it in. You need to arrange, right, to be able to do that. So it can be difficult for those reasons. So communities without access to those kinds of things, right, can suffer more in terms of their diet. Just the simple need for the time to be able to do it could be difficult. There could be a part of this, a distrust of the healthcare system, right? That is, they've been treated badly in the past in the healthcare system, so they're unlikely to come in. Now, that is a choice of sorts, right? Somebody unlikely to go to the doctor, they're choosing not to go to the doctor. But that choice is shaped by a way they've been treated in the past, right? And the way that they're expecting they may get treated again. Talking to some people that work with the Hispanic community in terms of health, they say that's very common around here, is that Hispanic patients believe that if they get COVID-19, they're not going to get treated for it, that they won't get the help. So whether that's true or not, they believe that, and that affects the way that they're going to behave. And of course, they believe that because it's been true of other diseases in other contexts. So even here with the underlying health conditions, even in cases where there might be choices that are playing a role, there is a racist structure underneath that is shaping those choices, is guiding those choices, that's tending towards one choice or another, right? That's pushing it in those directions. So even if underlying health conditions are the reason that African Americans and Latinos are dying more frequently, well, that still can be a product of racism. So what about like an inherent biological susceptibility? Perhaps that varies, right, by race. Perhaps that's an explanation. Perhaps African Americans are more likely, or Latinos are more likely because of some inherent biological susceptibility. And I think there's a tendency to think that this is necessarily a racist question. I don't think it's necessarily one, although absolutely can be. I've heard it floated very quickly as an explanation for why this developed in China. Maybe they're just susceptible to it, right? Of course, as soon as it takes off in Italy, that hypothesis vanishes with a new one about how Italians might be. So to float it here, right, could be the same sort of product of these sort of racist assumptions about how this works. That can certainly be the case. But unless you're a scientist working on this, you can't rule out that there might in fact be a biological susceptibility here, that there might be one in there. The people that I heard floating this first were doctors who worked on genes and that kind of thing and the relationship of that to disease. So of course, that's the question that they have front and center in their mind. Experts are going to work like that. We should be able to entertain this possibility, right, in the right kind of way without just saying that's the way it's going to work. Now, experts can produce a kind of myopia. That is, the experts, right, can focus on one thing or another because that's their area of expertise. Doctors who focuses on genes and the way that, you know, there may be inherent biological susceptibility varies among people are going to be interested in how that might be the case with COVID-19. And that's a worthwhile place to look, but of course, we shouldn't take those experts to be experts on what? Diabetes, right? They're not even an expert on other diseases, much less an expert on housing, an expert on social patterns, an expert on all of those other things. So even if an expert sort of raises this question in a legitimate way, not as a way of dismissing it, there still can be a kind of myopia there. We need to look at the bigger picture, right? And to think about how to connect across that. All right, so what does this mean for us? Like, how can we think through this? Part of it is a way that we respond to science. We don't know exactly what role each of these factors play, or how it played out, or where it played out. The truth is, any and all of them could be working together. So it's not that we need to jump in and say, here is the right answer. because that is a matter of science and investigation. So we need to be prepared to follow the science, right? We need to be prepared to look at the various science. One element that I saw evolving over the week actually starts to suggest that some of these hypotheses aren't true. So towards the end of the week, the claim has been made repeatedly that African Americans and Latinos die more frequently from COVID-19, but they do not get it more frequently. So if that's the case, right, then some of those hypotheses that were ventured earlier now have evidence against them. Genetic susceptibility, right? Okay, it doesn't look like they're susceptible to catching it. Maybe there's some kind of susceptibility to making it worse, but it couldn't be catching it. If we want to say that there was things that happened in the community, like churches meeting and so on, well, then they would catch it more, right? And not necessarily die from it more once they do catch it. So that seems to be out the window. The occupations hypothesis seems to be, this evidence seems to be against it. Of course, we're going to see this continue to evolve, right? Because this is the way science works. We're going to have another scientist come back with data shortly that's going to say, but if you look at it this way, right, you're going to see something different. This is not a problem with science. This is its strength, right? This is the way that it comes and helps and really tries to figure out what's in there. For us, for humanists who are not involved directly in trying to analyze this, how should we think about this racial disparity in deaths from COVID-19? I think it can highlight all of those different elements that we see behind there and say, we need to be addressing those. At this point, we need to support systemic changes to access to healthcare. That's going to mean across the board talking about food access and housing access. It's also going to mean access to doctors, right, and being able to get the kind of care they need. I think as humanists, we can look at what has been happening within our healthcare system and say the effort to essentially spread risk across the population while skimming profit off the top, which is what insurance companies try to do, is not working in a private manner. I mean, that's just not been able to sustain our communities in a just way. So yes, I think even though we don't yet know exactly which of these hypotheses is under there, we do know that there is systemic racism that is feeding whichever of those hypotheses is the case, and that we should address that kind of systemic racism in the healthcare system, right? There needs to be a push to move in that direction. There's always a danger when we start talking about racial disparities, particularly something from COVID-19. So one way that this came up this time is that there was a claim early on about how this disease was the great leveler, right? Everybody was vulnerable, everybody could be hurt. And then there's pushback saying, no, it's not the great leveler. Some communities are hurt much more than others, right? There is this kind of disparity. Both of those things are right, and we need to remember both of those in the right way. The danger of saying that it's not the great leveler, that it affects some communities more than others, is that the communities that are not more affected, that is, if you're not Latino or African American, you can start to feel safe. We saw this early on in COVID-19 when we were talking about older and younger people. It's more dangerous for older people, so younger people started acting as though they couldn't get it, right, as though somehow they were safe. This can replay right here, right? Our racial divisions can make us think this is a problem of them, right? If you're not part of that them, then you're safe, right, in one way or another. Even if you're committed to doing something about it, it becomes a sort of altruism, a kind of charity, like I'm going to help those other people and this doesn't really have anything to do with me. But fundamentally, from a humanist perspective, we are humans. We are in this together, right? Even if there is a difference in biological susceptibility, whether you're talking about older or younger, or whether different racial groups, or certainly people with different underlying conditions, right? There are these differences. We are fundamentally human, right? The virus can reach all of us. The effects of the virus have already reached all of us. Not in exactly the same way. We don't need that sameness, right? For us to feel connected, to us to feel threatened, for us to feel to be part of what is happening. So I think the virus has a power for us to stop and remember that we are all human, right? And that is how we are being affected by this. We need a just society so that we can be functional and deal with this. If one part of our community is more vulnerable, African Americans, Latinos, older people, doesn't matter. We're all vulnerable as a result. That is, we're going to be vulnerable in terms of the disease sticking around and spreading. It's not just going to stay in those other communities where you don't stay, where you don't go or whatever, right? Not connected to you in that way. It's not going to stay separate from us in a different place just because they're more vulnerable or they might have a greater chance of getting it. The costs and expenses that are going to come with this are going to affect all of us, whether that's in our insurance, whether that's in our economic situation, whether that's in our retirement portfolio. I mean, there's all sorts of different ways because we are connected, right? We are connected as humans. So learning about how COVID-19 does and doesn't affect everybody the same, right? Learning that there are different effects on different groups, different effects in different locations, should never be used to suggest, right, that we're not all human, that we're not all connected, and that we're not all in need of justice, right, to be able to be safe. And that's my thoughts for today.